This is basically a delayed presentation of a posterior impaction injury, posterior wall fracture, which was missed. This was missed because this patient had a trivial fall and complained about some groin pain, went to one of his relation who is a GP, who took an X-ray, like the first X-ray you saw when Dr. Vivek showed the pelvis X-ray, that was not very clear, but subsequent X-rays were very good. Like the first X-ray when you have in A&E, you may not get a very clear picture, and you should not ignore the patient's complaint and send him home. That's what this GP did. He actually saw the X-ray, didn't find much, sent him home. The patient was complaining of pain in the groin, especially on weight bearing. The patient continued to hop around and started giving complaints like giving way of the hip. He had a couple of falls also. Then he came back to the GP. That was about 3 weeks after the injury. So he had a CT, and the patient was referred to me with the CT scan. I do not have the X-ray because the X-ray has gone into, it's a medical legal situation. I just wanted to make everybody aware that do not neglect. If you don't see the proper X-ray, you ask for a fresh, good X-ray rather than sending the patient home, especially when you are busy in your OPD. This is what the CT scan looked like. Excuse me. This is already 23 days old. This is a posterior wall impaction injury in a young person. And this is not very clear, but you can see that this is sort of bloating up in the back, and probably there is a undistressed posterior column fracture in the 3D. This is all pictures I have got. So the diagnosis is a posterior wall fracture with undistressed probably one undistressed posterior column fracture, already 3 weeks plus. It's impaction. And osteoporotic, I suspect, because he had a very trivial fall. And especially this impaction injury are seen in osteoporotic patients, as you have seen in previous presentations. So the plan was to, because he's a young person, plan was to try and do a reconstruction. And we wanted to do it through the Cocker-Langenbeck approach with trochanteric osteotomy. You see, this is an intra picture. You see, this is an incongruent. This actually the head is subluxed backwards in the posterior aspect, and you can see that the incongruent starts here, and there's a fragmented articular piece here. You cannot, like Pranav's case, you cannot take them out and fix it because they are already porotic, hyperemic, and they are already attached to the subchondral bone. What I'll show you a video clip of what exactly we did. This is where the hip was subluxating, and it was axial traction was given. The cavity was irrigated. Then the impacted fragments, along with the subchondral bone, were elevated en masse. And using the head of the femur as a template, for the whole length of the impaction. It was quite a big impaction, actually. And then from the trochanteric osteotomy site, we had to remove the bone graft like cakes and pack them into the void that has been created after elevating the impacted fragments. So these were taken as cakes, and bone spreader was used to hold it distracted, and the bone grafts were packed into the place. And the head of the femur, of course, used as a template. And you cannot fix any implant here. Like Pranav Shah showed putting some lost K-waves. You cannot put anything here. You just have to rely on your the stability by the impaction of the grafts. So again, after that, you have to punch and get the stability by packing the area with the bone grafts. And I'll show you that this is a big chunk of lateral wall, the posterior wall, which was there. So it has to be put back into its original place after the checking that the hip is congruous, and it was fixed with a locking plate. I'll show you one more thing. This was so porotic, you can see in the X-ray, we have put 2 screws to fix the trochanteric osteotomy, but it was not strong enough. We had to put another 2 to work as tension band to support the trochanter from getting displaced later on, preventing the whole thing getting displaced. It was very soft. This is the obturator oblique view, and this is the iliac oblique view. This is the post-op. And we did a CT scan to check. This is what it looked like. There are small voids, and this patient came back to me after 2 years, and I asked him whether he feels any pain or any instability. He was actually jogging long distance, and he has started. He just demonstrated me how he finds himself absolutely pain-free and stable. So subsequently, he had some other injury. He came to me 6 years after the initial injury. This is what the X-ray looked like. But when I looked at the operator oblique, I found there was some diminution in the joint space. I'm showing you this enlarged view. This is where the joint space is diminished. So I asked for a further CT scan, and you can see that the space is diminished here, but he has no symptoms. This was done through this approach, and this gentleman has absolutely no problem. He is totally asymptomatic. The final outcome, clinically, has a full recovery, no deficit on examination either, but radiologically, he has evidence of osteoarthritis. If you classify according to Marta's grading, it will be good because there is already a joint space narrowing in the area of repair. So take-home message, adequate assessment of initial injury is essential to avoid late presentations. Reconstruction despite delay could be rewarding. En masse elevation of impacted zone helps to avoid cartilage fragmentation in lateral. See, once it is impacted and it has remained in the place for a long time, like 3 weeks is pretty long for an impacted fracture, you really don't have to lift it individually, the fragmented cartilage. You have to elevate them en masse and use the head of the femur and mold it onto the head of the femur. The impaction bone blocks grafting avoids collapse after reconstruction because your stability totally depends on how well you have impacted and the quality of the bone. Thank you very much.